Good afternoon, everybody. Welcome to the annual B. Frank Polk Lecture, sponsored by the Johns Hopkins Center for AIDS Research and the Department of Epidemiology. I'm Dick Chason and delighted to welcome you all here today. I want to start by saying a few words about Frank Polk. Frank Polk was a force of nature, and in a tragically shortened career, achieved extraordinary things. At his death in 1988, his obituary in the New York Times pointed out the extraordinary success of Johns Hopkins, largely led by Frank Polk, having received at that time $170 million for AIDS research. Most of it led by Frank. Frank really did everything under the sun. In the research realm, he started the multi-center AIDS cohort study here at Johns Hopkins in collaboration with other universities around the US, started the ALIVE study, did a large study on blood transfusion and HIV risk called FACS, and began international research in Malawi in a program that continues to this day. He started our outpatient HIV clinic to serve the participants of the MAX study, and he also was instrumental in starting the inpatient HIV service, which now bears his name. He also mentored an extraordinary number of individuals, and many of his mentees and their progeny and his progeny are with us today. He also helped establish a Fogarty International training program in HIV research, the HRP program. So just an amazing amount of productivity and contributions to science, medicine, public health, and scholarship in his shortened career. The Frank Polk Lectureship actually began in 1986 as the AIDS annual meeting that Frank and others organized to talk about AIDS research. And the first visiting speaker was Jay Levy from UCSF. And in 1989, it became the Frank Polk Lecture following his death in 1988. And you can see that over the past 40 odd years, we've had an amazing array of high quality leading investigators doing HIV research around the world. And we today have the honor of welcoming Carlos Del Rio from Emory University, where he is the chief of medicine, professor of global health, and co-director of the Emory Center for AIDS Research. Carlos did his medical training in Mexico at the Universidad La Salle in Mexico City, and an internship and residency at Emory University, Grady Memorial Hospital, with a sidebar visit to Johns Hopkins that we'll be hearing about briefly in his talk. He returned to Mexico, was a faculty member in infectious diseases there, and then returned again to Emory, where he rose through the ranks and eventually became the chair of medicine. Carlos's career has been extraordinarily productive, a research career that's resulted in well over 600 publications. His CV lists more than 2.5 pages of honors that he has received, including election to the National Academy of Medicine. He served in multiple positions on advisory committees to the US government, to the World Health Organization, UNAIDS, and others. And he served as president of the Infectious Disease Society of America. His research is focused on access to care for HIV and access to prevention, adherence, and he's also done important work in the overlap of substance use and HIV. I found one very fascinating thing in his background that during the COVID pandemic, the Secretary of Health and Human Services recognized him as one of the 50 most trusted experts in public health, a, a level of expertise sadly lacking in our country, in our government today. But Carlos's leadership during the COVID pandemic was really important and exemplary. So with that, I'd like to ask you to join me in welcoming Carlos Del Rio as the Frank Polk Lecturer.
Thank you, Dick and Shuri and others. It's a pleasure to be here at Hopkins, and it's really an honor to be invited to give the Frank Polk lecture. Let's see. So those are my disclosures. Not a lot of stuff, but I still wanted to put them up. So Frank Polk, as you heard, he was an incredible person. He was a clinician scientist. He was an activist. He was a champion of human rights. I knew him briefly. I met him briefly when I was here at Hopkins. But then I learned a lot about Frank, interestingly, through a collaboration I developed with Ken Nelson, who's actually there in the live cohort. Ken Nelson and I ended up working together multiple times in the Republic of Georgia. And I spent a lot of time in Tbilisi with Ken, who I miss dearly. He was an incredible teacher, an incredible person, an incredible friend, fun friend to travel with. And he talked about Frank a lot and told me a lot of things that I really treasure. So as Dick said, I went to Emory, and I went to Emory for residency in medicine in 1983 because I wanted to be a cardiologist. And J. Willis Hurst was chair of cardiology or medicine at Emory, and I wanted to be a cardiologist. And interesting enough, if you read up Frank also wanted to be a cardiologist. So. And then, but something happened to me, which is, as Dick said, I took a detour to Johns Hopkins. When I started my second year of medicine residency, I was traded to Johns Hopkins. There was somebody at Hopkins that needed to spend a year in Atlanta, and Victor McCusick and Willis Hurst figured out this thing in which I would come to Hopkins and be this person, and this person will go to Emory and be me. And something that you probably wouldn't get away with it in this day and age. But back then, I was just told, on a Thursday, I was told Monday you start at Hopkins, and I started in the oncology service with Marty Abeloff as the attending, and then I went on to Osler 8. I was in the Lonco firm back then. Lonco was in Osler 8, and my attending was John Bartlett, and it was meeting John, and then through John meeting Frank. But meeting John, not only as me attending in Osler 8, but then when I did ID, he was my attending. That convinced me that I didn't want to do cardiology. I wanted to be like John Bartlett. And really coming to Hopkins is what changed my life. After Hopkins, I decided to go into ID and did an ID fellowship. So if I hadn't come to Hopkins, I probably would be a cardiologist today. And that's how interesting life is. But anyway, this is the class of residents when I was here 84, 85. And in fact, that's me in the middle of this illustrious group. But as Dick said, I at the end of my training, I went to Mexico where I practiced, and I was the director of the National AIDS program for about 8 years. But in 1996, I returned to Atlanta, and I've been in the faculty at Emory, spending a lot of times in my clinical service, either at Grady Memorial Hospital or at the Grady Infectious Disease Clinic, which is our HIV outpatient facility. And this was, again, late 1986. I started in faculty in November 1986. Highly active antiretroviral therapy had just appeared. It was really that turning moment that we all were privileged to live in which HIV went from being a death sentence to all of a sudden being able to keep people alive. And I was convinced that we were going to get ourselves out of a job. We had an AIDS ward, and I said, this is going to end. We're going to end this with antiretroviral therapy. There's not going to be a need to have people hospitalized. But pretty soon it became clear to me that we were actually seeing, I would say, 4 groups of patients, right? We were seeing those who didn't know they were infected, and they were coming in, and they were still being diagnosed, many of them with advanced disease. There were those that made us very happy. They were in regular care. They took the medicines. They came to clinic. They were fine. There were those that were like in intermittent care, and I almost call them the whales. You would see them for a while, and then they would disappear in the depths of the inner city. You would not see them for a while, and then they would come back into the hospital, and you would see them with an OI. And then there were those that were truly not in care. You never saw them in clinic, and you only saw them when they came into the hospital, but then they would disappear again. And it was those last two groups of patients who, circle in and out of the hospitals that frequently people call the frequent flyers. But I got very interesting in those groups of patients and trying to understand the reasons why people are not diagnosed or fail to engage in care really has been the center of my research. And it was that clinical observation of trying to tackle what made it different, what was it that made it differently. So in 2001, I was invited, because of the work I was doing, I was invited to give a talk at Croy, and I entitled the talk, The Perilous Road from Detection to Undetectable. So why is it so hard to go from being, to having diagnosed with HIV to being undetectable? And first of all, it was pretty clear that having antiretroviral therapy was dramatically impacting HIV. We were seeing a rapid decrease in AIDS deaths, but we were also seeing a rapid increase in HIV, or back then we call it AIDS prevalence, right? More people were living longer because simply, new infections were still occurring. But if you thought about antiretroviral therapy, you could say, well, we could potentially decrease the incidence of HIV infection, we could decrease the incidence of AIDS, and you could decrease mortality. But as a result, you are going to see an increase in prevalence. And what is the impact of that going to be? And our inpatient service at Grady, we clearly saw a decrease on deaths happen in the inpatient side as a result of advanced HIV. But what we didn't see is a decrease in the number of admissions. We saw a little bit of a drop, but then it continued to be pretty flat. The number of new people being diagnosed with HIV was something that we kept on seeing. And it was because there were actually a lot of barriers to go from diagnosis to undetectable. And those included, perceptions of risk, seeking HIV testing, having an HIV test offered, accepting the test, receiving the test results, getting referred to care, entering care, staying in care, adhering to therapy. So it was just a bunch of barriers that kept people from not achieving the goals that we wanted. Also, with one of our MPH students, I looked at people who had been diagnosed in the hospital during a hospitalization. And there were 115 adults who had been diagnosed with HIV during a hospital stay in 1997. And their median TC4 count was 47. But what's interesting is that 60% of them had access to the hospital care system in the previous 12 months. And many of them had either been in the ER or been in the urgent care center. But HIV had rarely been considered initially. And in fact, by the time they presented with an OI is when they were diagnosed. So based on that, I applied for a grant and got a grant to implement a opt-out HIV testing in our urgent care center. And, it was, you can see the results here. When we went from risk-based to routinely recommending testing, the number of clinic visits really was about the same, about 19,000, almost 20,000 visits. But the number of HIV tests conducted almost was a 2.5-fold increase in HIV tests. And the number of new diagnoses also went up to by 1.6-fold. But also the number of people that actually entered care, that learned their HIV test result and entered, was quite significantly increased, right? Almost a 2-fold increase. So clearly, implementing a non-risk-based approach is something that made a big difference. And again, CDC has been recommending this for a long time. Hopkins has been one of the leaders in doing HIV testing in the ERs and other places for a long time. But I think the recommendation of opt-out testing in healthcare facilities is one of the most ignored CDC recommendations ever, because there's still many hospitals that do not do this on a routine basis. But the other thing that bothered me is when we looked again at, newly diagnosed people in 1999, again, 135 people newly diagnosed when the hospital, no different. They were, had very advanced HIV disease, but almost 20% died within a year of diagnosis. And I just said, well, this doesn't make any sense. What's going on? Well, what was going on is that they were basically either didn't make it into care or they were dropping out of care. But the bottom line is that 1 year after diagnosis, 40%, only 12 people were undetectable. The rest of them were not. So the percentage of people who are undetectable is pretty low when you think about it because of all the barriers that occurred. So I got really interested in looking at, what exactly happened and what is it that people are not being linked to care and what is it that keeps people out of care and what can we do to improve this and what can we do to decrease the fact that the majority of people who were diagnosed in the hospital we're not going into HIV care, or we're dropping quickly out of HIV care. And, in a quick analysis, we looked at who were the ones that made it to clinic. We called them regular attenders, and who were the ones that didn't make it to clinic, and we called them non-attenders. And one big difference was crack cocaine use. Crack cocaine use in the past 6 months was a significant difference between those that went to clinic and those that didn't. And you can see other things that were of interest, incarceration, et cetera. But one of the other things is the context, who you were hanging around with. And but to me, the crack cocaine was the one that really stood out. And therefore we said, well, we need to focus on that. Now, at the end of that presentation that I did at Croy, I built this that I call the Piot pyramid. And it's not called because of Peter Piot, but it's actually Maurice Piot, who was a TB researcher. Maurice Piot in 1970 had published a paper in which he proposed this model for TB care of, those that are suspected with TB, that seek care, that are examined, that are diagnosed, and that actually begin therapy, and just showing the big drop that occurs over time. So looking at that, I said, well, let's propose a pyramid of HIV care. And I said, there are about 5 million people at risk behaviors in the US, about 600 to 900 living with HIV. Of those, about 500,000 know they're infected. Of those, about 300,000 are in care. Of those, about 200,000 are antiretroviral therapy, and about 90,000 are suppressed. And again, this was all calculations based on data that existed out there from Sam Buzzetti and others, the HOP studies, et cetera. Well, after that Croy presentation, I tried to publish this, and I sent it to multiple journals, and it got rejected from every single one of them. And I think most of my reviewers must have been from CDC, because I got a lot of backlash saying that this was not possible, that our suppression rate was much higher in the US, we were doing way much better, but really without presenting any data. So this was 2001. It wasn't until 10 years later when we finally were able to get this published in CID. And it was actually through the persistence of Ed Gardner, who by then was in Colorado, who said, Carlos, we really have to publish this. And thank God, it took 10 years to eventually this concept appear. But as you can see, he first did a different approach. He took the Maurice Piot's pyramid and did it very similar to that. And then, he presented the data in this paper that we published in CID, talking about this engagement in care, which this eventually became known as the HIV care continuum, or the HIV care cascade. Very quickly after that, though, we said, in that paper, we said, well, we think only about 90% of HIV-infected persons in the United States are virologically suppressed. Well, within months of us publishing that, the CDC came up and said, no, it's actually 30%. And, they could not accept that. But the reality is that no matter how you count it, you still see that 50% of people diagnosed with HIV are not engaged in care. And I think that becomes the big challenge and the big, implementation challenge that we've all had throughout, at least that has been most of my research, is looking at what can we do to change that and to improve the rate of virologic suppression. Because if truly, especially nowadays, if we know U equals U, it's not only about improving the health of the individual who becomes undetectable, but it's really about decreasing HIV transmission. So we went on and applied for this study that CDC was asking for proposals. And we got funded to do this study called ARTAS, which is really looking at an intervention to get people engaged in HIV care. And this was a randomized trial to look at a case management intervention to link people newly diagnosed with HIV into primary care. And what we found is that the intervention was efficacious in linking people to care, and actually that was maintained over 12 months. But again, crack cocaine was independently associated with not being in HIV care over 12 months. And crack use was also associated with continuing high-risk sexual behaviors. And the primary paper was published in AIDS in 2005. But of course, a bunch of other papers were published as a result of the data analysis, and of the many postdocs and fellows ended up doing data analysis and working on the studies, which I think is something that I always say to postdocs and to PhDs and others. The opportunity of joining a big study is all the richness of data that exists, and then you can analyze and you can do a variety of different studies. But what we found also is we actually, part of ARTAS, we did a survey of providers as well as a survey of patients. And what we found is some interesting things, right? To providers, they thought that the biggest barriers to HIV care was substance use, mental health issues, social support, transportation, and insurance issues and cost of care. For patients, it was more like, I feel well, I have no symptoms. Yes, cost is an issue, but I'm worried that someone will discover about my HIV status. So stigma is a big driver of not going to care. Transportation was an issue, but it wasn't as high. It was just as high as stigma. They were scared about an HIV diagnosis. And many of them said, I just don't know where to go. Despite the fact that you tell me where the clinic is, I still don't know where to go. So obviously, I think when you think about what are the barriers to care, we as providers sometimes have a very different perspective than what the patients have. And I think we need to ask the patients, we need to ask the users, what are the issues that make them not come to care? And what you realize is that stigma is a major driver. I can tell you that, for example, we discovered that the bus route that went down Ponce and stopped in front of our clinic, well, the bus driver said, we'll stop in front of the clinic. and said, HIV clinic? Of course, nobody wanted to get off the bus, right? I mean, because nobody wanted others to know that they were in the clinic so one of the interventions was actually talk to the MARTA bus company and say, please, call this stop something different, but don't say this is a stop for the HIV clinic. But that artist intervention actually became a Debbie, a CDC, named it a best practice and continues to be an intervention that is used by health departments across the nation as a way to link people to care. But I continue to be obsessed about people that we still saw in the hospital and continue to be obsessed about, crack use as a major driver of not going to care. So was working with Lisa Metch, who is an investigator back then at University of Miami, who I met through Artis. We applied for this NIDA R01 and got funded to look at what can we do. The idea was, there are people in the hospital that we see, they have HIV, they have a concurrent substance use disorder. What can we do to actually use this hospitalization as an opportunity to get people into care? And the hospital is a great place to intervene. You have, they're frequently connected to care. You see people there who have high viral loads, who are unprotected, sex. And the hospitalization may be that teachable moment, right? Where you can actually get people to say, well, maybe I want to change something. Maybe I want to start therapy. Maybe I want to do something different. So our specific aims was to evaluate the impact of an intervention to increase use of primary care and entry into drug treatment. And so this is the study participants. This is the people that we enroll in the study. And you can see that, they had frequently been incarcerated. Many use illicit drugs, a lot of alcohol use, and many had also, very few had actually been in drug treatment. Now, the types of drugs they use, was very clear that while crack was one of the drivers, especially in the South, there were many other illicit drugs and heavy alcohol use. Very little crystal meth back then. And interestingly, in the South, back then, not a lot of opiates, not a lot of heroin, as opposed to the epidemic here in Baltimore, that there's a lot of heroin driving the epidemic. But again, what we found is that there was a group of patients who had never been in care. We found them in the hospital, and yet they were frequently hospitalized, so they had been hospitalized, but many of them had never seen, 52% had not seen an HIV primary care provider in the past 12 months, and 50% had not seen an HIV provider in the past 6 months. So the never in care was obviously a big driver of why, we were diagnosing people, but of course they were not linking to the outpatient clinic. And again, crack cocaine and heavy alcohol use were associated with not having an HIV provider. The other thing that was driving a lot of, we discovered, is the impact of food insufficiency and intimate partner violence in driving people for not being in care. And in fact, Amita Kaloki, who was back then a resident working with us, now has really developed a career around looking at intimate partner violence. But she was the one that came to me and said, look, we ought to look at intimate partner violence as one of the drivers of not getting people, especially women, coming to care. And sure enough, she was absolutely right. And that was actually what was one of the topics that we initially did not have in the grant, but Amita was able to get us to introduce that. And I think I'm very glad she did, because it really made a big difference. But the big challenge is even if you get people into care, it's actually retention in care. what do we need to do to get people retaining care? Because in fact, that is the biggest challenge that we have in our HIV care continuum is really, we get people diagnosed and linked to care, but then they dropped out of care. And this is not something happens just only in the US. We see this globally in our PEPFAR clinics and other places in which people drop out of care and then they appear somewhere else. And this obviously has a lot of implications, but the major public health implication is that most of the HIV transmission occurring nowadays is happening from people who actually have been diagnosed but are not in care, and therefore they're not virologically suppressed. So we really need to get those people re-engaged in care, and we need to get them virally suppressed. So one of the projects that I got involved with is actually from a request from HRSA, the Institute of Medicine looked at trying to come up with metrics, because we talk about retention and care, but the reality is, how do you define it? What is the metric? What does it mean to be retained in care? And in this Institute of Medicine study, we all agreed that it needed to be 2 or more visits in the preceding 12 months, at least 3 months apart, to say somebody retaining care. But coming up with definitions was actually pretty important, and you can see in this continuum from testing to virologic suppression. But if you look at this, it becomes you realize that retention and care has to be a continuous variable. And Jonathan Colasanti, who was one of our fellows, worked in the study with me looking at, okay, you get people retaining care in the clinic, but what happens over time? That same patient that was retaining care at 12 months, or who were retained in some other clinic, over time, because frequently you say, well, they stopped coming to our clinic, but they went somewhere else. But the reality is, if you look at 24 or 36 months, they drop in all the places. Now, if you take a snapshot at any time, you see the retention and care is really good. And frequently when you read, HRSA or Ryan White data says our retention is really good, it's because they're looking at a one-time snapshot as opposed to looking at the longitudinal care, what happens over time. And this is one of the biggest challenges, is not only retention at one time, but retention over time, that I think is something that we really still need to tackle. And when you look at people who have been successfully retaining care versus those that have not been retaining care, Rupali Doshi, who's one of our fellows and a postdoc, looked at this data, and what she found is that the big difference is that in the most recent HIV viral load, in those that were successfully retaining care, about 75% were undetectable, versus those that were not retaining care, meaning they come in and out of care, only about 50% of them were undetectable. So again, this is thinking about the antiretrovirals we had back then, but you start to realize, what's the role of long-acting agents? Can we get those people that we don't see as frequently, suppress if we use long-acting agents? And re-engagement is also another area that we got very interested in, because really it's one of those things that has not been really studied as much as linkage and retention. And the populations that need to be reprioritized for re-engagement are those that have been hospitalized or those that have been recently incarcerated. And that's the populations that we have the opportunity to get them back into care, to get them linked back to care. One of the things that we found also, that I'm not showing you the data, but is when we implemented our HIV opt-out testing in the emergency room, frequently it was not new diagnoses that we made, but it's actually people who were previously diagnosed who had fallen out of care. And having the HIV testing in the ER gave you the opportunity to get them linked back into care. So again, together with Lisa, we went ahead and proposed to the NIDA CTN, the Clinical Trials Network, a study in which we wanted to evaluate an effective strategy to improve the HIV care continuum and to decrease viral suppression in persons who use drugs. And we were focusing on people who were hospitalized, and we looked at people who were hospitalized in 11 hospitals across the US. And we were looking for people hospitalized who had a detectable viral load, who had a low CD4 count, and who used opioid or stimulant or heavy alcohol, and who had a pretty good survival possibility, because we were going to follow them over time. And what we did is we randomized them to a patient navigation intervention, to a patient navigation plus contingency management, or treatment as usual, whatever, just getting a referral to the clinic and hope for the best. So patient navigation is an important intervention. This is a term that was created by Harold Friedman in 1995 in Harlem. And it's a barrier-focused intervention, first used in cancer care. And, it really is, the characteristics is it provides an individual with a defined episode of care, has a defined endpoint. It targets a defined set of health services. It focuses on identification of individual and patient-level barriers to accessing care. And it aims to reduce delays in accessing the continuum of care services. But the most important thing is that what Harold Friedman showed is that when this was implemented, all of a sudden mortality among black women with breast cancer went down. So clearly it was a very important way to decrease mortality. In HIV care, we've used patient navigation probably starting in 2007. And patient navigation has shown to increase medical care appointments, et cetera. But it really, at this point in time, there was no randomized trial to show that patient navigation actually made a difference. And that's something that you frequently find. You do these interventions that we do in clinics, and there's no data from randomized trials or other studies to actually show that this makes a difference. We just think it should. Contingency management is basically, a systemic reinforcement of desired behaviors. And you can do this from a variety of ways. It's been used very effectively in alcohol and substance use disorders. And it's also been found in some studies to be helpful in cocaine addiction. And so here's the study design that we did. And when we looked at the hospitals, it turns out that 4 hospitals were in the South: Miami, Atlanta, Birmingham, and Dallas. And 4 hospitals were in what I call the non-South, from LA, Chicago, Pittsburgh, Baltimore, Boston, Philadelphia, and New York City. And first of all, we found some interesting differences. What you found is that when you look at everybody who'd been admitted over approximately 13 months, about 51% of the admissions were in the South and 48% were in the non-South. But a big difference was in those that were hospitalized in the South, only about 13% were virally suppressed at the time of hospitalization, versus in the non-South, which is about 33%. And you can see here what their median viral loads and CD4 counts were. So a much sicker population with HIV. Many of the persons hospitalized with HIV in the non-South were there for other reasons. They were there for surgery, or they were there for other reasons, but not necessarily for advanced HIV. And you can see that the other interesting difference was that there was a big difference in hepatitis C prevalence, right? The non-South, about 41% of them had hepatitis C, versus in the South, which was only about 20%. Unstable housing and ever in jail the last 6 months was really no different. But when you looked at last HIV care visit in the last 12 months, it was almost double in the South versus the non-South. And whoever being in HIV treatment, in substance use treatment, you saw something, there was a lot more substance use treatment outside the South. A lot of it has to do with the fact that there was no Medicaid expansion in many of the southern states, and therefore less ability to provide the additional wraparound services that you wanted. So the possibility of not being virally suppressed when you were hospitalized, a lot of it, if you see, a big driver was being in the South, and a big driver was, the older you were, the more likely you were to be virally suppressed. Anyway, so what were the findings? What did we find in the study? Here's the characteristics of the patient population. But the most important thing is that what we found is that over the ensuing 6 months that when we did the intervention, is you actually saw the percentage that became virally suppressed go up to almost 50% of those that use the patient navigation and contingency management. So there was a big difference there. But as soon as you remove the intervention, which was the primary outcome, so the intervention lasted for 6 months and then it went away, there was no difference. It just went away. So I think that taught us something pretty important, which is you have to keep the intervention going. You cannot just take it away, because if you take it away, you're going to lose the benefit. But clearly it made a big difference. But the other thing that we found is that if you look again, you compare South versus non-South, at the end of 12 months, how many were suppressed? Well, clearly there was a big difference between non-South and South, right? You can see most of the hospitals in the South, whether it's Jackson Memorial in Miami or Grady in Atlanta, where Johns Hopkins was at 25%, 26%. UAB versus those that were in New York or Boston, other places were in the 50, 60%. Again, talking about the impact of wraparound services, other things that are driving this. There was no difference, however, in the mean number of hospitalizations. And there was again, an increase in the number of times somebody went to a provider, but then it went away, right? It disappeared. And and again, a little bit of an increase in the number of also who went to substance use treatment. So I think what we found is that clearly this is an effective intervention, but I think the challenge obviously is that the number of sessions we did, was not sufficient enough. Maybe we would have continued this beyond 6 months, would have been a lot of very important. And in fact, would continue the intervention beyond 6 months was what we needed to do to really achieve the 80% levels of the national AIDS policy. Now, a lot of criticism we got is whether contingency management was a dead strategy, and HPTN 065, which was another study that we did, looked at financial incentives. And again, financial incentives does not increase linkage to care of virologic suppression. So a big question is, well, is contingency management dead as an intervention for HIV care? And I'm not sure it is. In another study that we did, we showed that contingency management, sort of a financial incentives as part of a commitment contract actually made a difference and increased viral suppression. And this was, a little bit more complicated intervention in which you had the financial incentives, but you also had a commitment contract. And the person had choice. They could choose between getting an incentive every time they come or waiting until the end of the year. And by having choice, the percentage of people who became virally suppressed actually went up significantly. So I'm not sure if contingency management is a dead intervention, but I think it's one that still needs to be studied further to really understand how best to implement it. So could we provide integrated care? Could we do something that actually improved not only entering to care in substance use treatment? Because, poor access to effective substance use treatment is a major driver of continuing HIV in many populations. And again, we did the study with the idea of getting people not only into primary care, but also getting them into substance use treatment and doing this through a patient navigation intervention. And we did this by designing, we did it in Atlanta and Miami, and we designed for this study what we call a retention clinic. And the retention clinic was a pretty simple approach. In other words, you didn't need to make an appointment. All you needed to do is just to show up. And when you showed up, you had to see either a mental health provider, a substance use provider, or a medical provider. You came in at any time you wanted. And there was a patient navigator. And more importantly, we also offered you food there. People have to eat. So if you came to get food, you had to see somebody. And we did a sort of an evidence-based substance use treatment intervention. And the primary outcome was, viral suppression at both 6 and 12 months. And then we looked at other variables such as entry, how many came to clinic, et cetera. Again, mostly, 60%, 37% female, mostly African-American. And you can see, a lot of people with very low incomes, with many with housing insecurity, food insecurity, et cetera. So a very challenging population. Many of them you can see here with viral loads in the 30,000 with a low CD4 count. And very few had actually seen a physician in the last 6 months. Most of them had positive UDSs and had a lot of drug use. Well, it turns out there was no difference between the control and the retention clinic, and I think it has to do with the fact that we provided the patient navigation, and the patient navigation, the people that were able to get virally suppressed went up in both arms, regardless of whether you had the retention clinic or not. And also we saw a decrease in alcohol use and a decrease in substance use and a decrease in the proportion that had positive UDS, and regardless of, with no difference between one and the other. So there was no difference in viral suppression. And with, at the end of 12 months. And the retention clinic did have significant, did engage more in substance use treatment, and but substance use declined in both groups, and mental health improved significantly in both groups. So I think adding mental health also made a big difference when we did this. So it was not just about providing HIV care and substance use care, it was really the mental health component. And again, there was also a study I would tell you it's really hard to publish negative results. But OFID published this recently, and I appreciate them doing that. So the last study I'm going to tell you about is HPTN 078, and this was a study looking at engagement for men who have sex with men who are not virally suppressed. And Chris Bayer, who used to be here, when he was here, he actually was the PI for the study, and I was a co-investigator in the study. And here, we recruited MSMs who were not virally suppressed, and we basically randomized them to enhanced case management or standard of care intervention. And again, what we found, at baseline, the median viral load was about 20,000. And at 12 months, 48% were virally suppressed with no difference between the arms. There was no difference between the case management or the standard of care arm. So just by being in the study, the populations increased their viral suppression. And I think it shows, again, the value of doing this kind of studies in improving population health, because even the ones that are getting the standard of care intervention are getting more touch points, are getting more calls, are getting better, are getting more than the usual population. So having the studies actually, I think, improves population health. It's not just about the results of the study. It really is about how you partner with the community and do the studies in such a way that then participants benefit from it. There's that little bit of that Hawthorne effect. So the other thing we found is that, that men who have sex with men who were not in care were willing to re-engage in care. And nearly half of them actually were able to then get virally suppressed at 12 months. So while case management did not improve this, I think it was really being part of a study that made a big difference. So I was going to also tell you about this because I think this again talks about implementation. When Jonathan and I were talking about how hard it is to become virally suppressed, he said to me, well, part of the problem is the clinic. I said, what do you mean is the clinic? He said, yeah. So what he did in figure A, he mapped what happens from when a patient arrives to when a patient finally becomes, gets an antiretroviral therapy. And he put in red every time that we had to stop. Every time we told the patient, oh, you're missing this piece of paper, or you're missing this, or we can't see you today. And what he said to me is, we're going to break down this. We're going to try to make it simple. And what he did is he implemented then intervention B. And figure B is what happens now in our clinic. You arrive, you basically, no matter what time you arrive, you get seen, you get started on therapy right away, and we get you into care immediately. And we get you an antiretroviral therapy as soon as we can. And guess what? Viral suppression has increased. So part of the problem is the clinic, and as Dave Malbranch said in a conference, in one of the International AIDS conference, and I totally agree with him, if we ran a restaurant and people didn't come to a restaurant, you wouldn't ask what's wrong with the clients. You would say, what's wrong with the restaurant? What's wrong with the food? Well, we need to figure out the problem is not the clients. The problem is us. We need to change our clinics to make it more accessible so people actually come into care. So when you're thinking about implementation interventions, think about what you need to do in your clinic to make it more friendly and more easily accessible so people actually are more likely to come and be seen. So I'll wrap just by saying that, I've learned over time. It's not advancing. Stuck. What happened? So I learned over time that there we go. I learned over time that when I think about HIV in Atlanta, and I'm saying in Atlanta, but it's multiple. It's really at in many cities, including Baltimore. HIV is at the center of not only it's not just an infectious disease. It's really a substance use disorder. It's a mental health illness issue, and it's an issue also around poverty. And you think about HIV when you're trying to address it, you really have to think about not just as we do as an infectious disease physician, here's this pill, take this drug and you're done. It really has to think about how do we integrate a care for mental health, substance use, and what interventions do we have to address poverty that is driving a lot of our epidemic. So really this difficult road from becoming HIV infected to getting retained to care to getting into virally suppressed, really we have to look at all sorts of issues. And again, I didn't go into many of this, but I'll just mention them because stigma, fear of diagnosis, low literacy, transportation, all are driving this and all are making it harder and harder for patients to achieve the goals that we would like to achieve. So yes, we do have, antiretroviral therapy that gets you viral suppress, and sustained virologic suppression is really good. But this implementation gap is this health system challenges, is this biopsychological challenges that really are keeping patients from being able to cross that implementation gap. So I'll end up by just again showing you the HIV care continuum and just telling you that I think over the last 20 years or so, my research program, each one of those studies has really focused on different stages of the HIV care continuum and trying to improve it. And while I think a lot of the the science and the studies and the papers and the mentoring of trainees has been incredibly gratifying, I think I would tell you that probably the most gratifying day is the day I got a call from the White House saying that the president was going to sign an executive order to improve the HIV care continuum, and I was invited to go to be at the signing of this executive order. And when you realize that your research is actually leading to change in policy and leading to an executive order signed by the president, it really means that your research is actually having a significant impact and is really making a big difference. And in fact, the National AIDS Strategy has those indicators around diagnosis, linkage to care, retention to care. So really all this work that we did has actually impacted the way we think about HIV, not only nationally, but globally, and how do we think about interventions. So in summary, I think delays in testing, delays in care, and dropout of care continue to be the three big problems in HIV today. We can increase testing, and there's United States Public Health Service guidelines to increase HIV testing, and there's CDC guidelines. In delays in care, I think linkage to care artists work very well. I think in retention and care, it's a little harder to know what works. I think there we don't have yet an intervention that is proven to be as effective as others. So there's a lot of research that still needs to be done. And I think, I didn't go into this, but I do think that long-acting agents have a potential to make a difference and have a potential to allow us to get people, because we saw people that came to our clinic, they just weren't virally suppressed. So can we get them virally suppressed with long-acting agents is one of the big questions that we're currently studying in collaboration with colleagues in San Francisco. So I just want to end by thanking people at the Emory CFAR, co-investigators and colleagues that have worked with me, students and fellows that have worked with me over the years, and the funders, primarily NIDA and NAID, who really have supported a lot of the studies. And of course, the people that I want to thank the most is my research team, because they are really the ones that are doing the job. They're really the ones out there finding our study participants. This guy over here, OC was a syphilis tracking for this guy over this side. And he's the one that finds our study participants and allows us to have retentions of 90% plus. And he taught me something that I'll end with that. And, he said, look, doc, for your studies, I don't need somebody's name and phone number. That doesn't help me to find them. I need to know what's their nickname and where do they hang out. And where do they go when they get in trouble? And if you give me those three things, I'll find the study participants and I'll get them back to the study visit. And sure enough, that was the information that he needed. So a lot of the stuff that I've learned by the people that work with me and that are part of my research team. So I'm really incredibly thankful for their interest and their collaboration over the years. So with that, I'll end and happy to answer any questions.
Questions? Well, I'll start with a question, and Carlos, I don't know if I saw a hand up there, but I'll get to you in a second. Just so with your decluttering the clinic diagram, you said that there was an improvement, but what is it? Because with your randomized trials, at the end, you had 50 to 70% of the people still unsuppressed.
I think it's two things. I think is that decluttering is the more rapid start on therapy. That's making a big difference. And quite frankly, single drug therapy, primarily with INSTIs, with that has made a huge difference. I mean, right now in our suppression rates in our clinics are close to 90%. We still have people that fall out of care and drop out of care. And we still, unfortunately, have in Atlanta a lot of new diagnoses. And that continues to be, I think, in great part, and they didn't go into this, we simply have not done the scale up of PrEP that we need to do in order to really, so I think ending HIV transmission is not only going to require very high levels of viral suppression in the population, it really requires big scale up of PrEP, because otherwise you're just not going to get there. But it has made a big difference. And I think rapid entry into care and rapid start of antiretroviral therapy has made a big difference.
That was a great presentation. And it's really impressive how the decluttering of the clinic is leading to these improvements. And I was also wondering, how do you think what do you think the impact of take-home tests for HIV antibodies is going to be as they
again, it's a wonderful intervention. Patrick Sullivan in my group has done a lot of studies looking, at mailing testing and home testing. It makes, for some people is the right thing to do. In fact, you can do not only HIV testing, but actually STD testing. And people who are in PrEP, they don't need to be tested in the clinic. You can actually mail them a kit and they can be tested at home or send their stuff and then be tested in the clinic, but not having to come themselves. So I think, again, we need to make it as easy as possible for people to access care. Sorry.
Yeah, thank you very much. Very inspiring. You mentioned that in your presentation something around non-risk based testing that made a difference at the beginning of the outbreak. I'm wondering how you strike the balance between non-risk based testing and limited resources that you're having currently in such a setting where you can universally test people.
Yeah, I mean, I think we need to use opportunities to test people where they are, right? And I think in hospitals, and Hopkins is a great example that Hopkins has done this in the ER for years. Hospitals like Hopkins, like Grady, that sit in the middle of a very high prevalence situation. Grady, we've calculated in a study we did, we figured downtown Atlanta, the population in Grady has an HIV prevalence of about 1.5%. At that kind of prevalence, you should be doing testing and people should not come to the ER and at least not be given the opportunity to be tested. I would tell you something that before we started doing routine testing, one of the things that would drive me absolutely crazy is see somebody in the hospital newly diagnosed, let's say with pneumocystis. And the person would say to me, well, I was here 6 months ago and I got tested for HIV. And you were like, really? So you go back into the medical record, try to find out, no, yeah, they've been there 6 months ago, but they had not been tested for HIV. But the person assumed that because we drew a bunch of blood, we must have tested them for HIV. So I think that people are thinking they're coming to the hospital and getting tested because you draw blood and we're not doing it. So I think clinic and hospitals in high prevalence areas should be doing more testing. And it's been a hard thing to implement. And I would tell you a lot of resistance has occurred and not many places are doing it, unfortunately. I think there's still opportunities to test and to do very targeted testing in populations that really need it.
You gave a few nods to the implementation scientists talking about the implementation gaps. You also talked a lot about trying to make treatment fit people's needs better, and obviously the long-actings are moved that direction. It also seems like some of the early experiences are that it's harder to get those drugs, that modality to people and get that implemented within healthcare systems and past insurance companies. I'm just curious if you have any thoughts or reflections on ways to speed that up, and maybe what some of your early experiences are there.
Well, I think, for example, with cabotegravir rilpivirine, when you think about it, the FDA approved it as something you can do in people who are virally suppressed. In other words, those that are doing well are the ones that are actually approved to then change from oral therapy to injectables. It was really Monica and Gandhi and a couple others who said, no. And, in the ACG study that we did as well, looking at, no, we can actually take people who are not virally suppressed, start them on therapy with long-acting agents and make a difference. But we need to get that to be recognized as a valuable intervention. And I think we need to somehow show that if you can get somebody virally suppressed and not getting hospitalized and not getting them to get an opportunistic infection, I think it makes a big difference. And I think doing those sort of cost saving in the health system studies, but also if people can, keep a job and continue, being productive, I think it's something that we need to think as significant. I mean, I was talking to one of our patients the other day who happened to be in the hospital for a non-HIV related issue. He had a surgical complication and was in the hospital. And his biggest concern was he wanted to make sure we continue his antiretrovirals because he said to me, Doc, I cannot afford to let my HIV wake up again. And he was absolutely right. And he wanted to be sure that he got his injection at the right time, et cetera, et cetera. And we need to listen to what participants are telling us and need to make, because most people want to get their health better. It's just that the system is so broken that doesn't allow them to do that, right? But yes, I would say implementation science is really important. We need to continue doing more because a lot of the challenges we have are around implementation. We got the tools, but we need to implement it accordingly.
Okay, before we finish, I'd like to invite you all to come to the poster session and lunch down the hall in Feinstone Hall. And to conclude, I'll just say that I started by saying that Frank Polk was a force of nature, and Carlos Del Rio is clearly a force of nature who's just given us a tour de force presentation on engaging people in care, keeping them in care, and getting us to zero. So thank you very, very much, Carlos.
Thank you.